Thank you, Dr. Jyoti, for the kind introduction. At the outset, I would like to thank the organizers for having me on board this year again to discuss the best posters from SABCS. So the topic that I'm going to discuss is from a multicentric trial funded by NHS UK, the SMALL, which is the open surgery versus minimally invasive vacuum-assisted excision for small screen-detected breast cancer, a phase 3 randomized trial. Looking at the background of this structure of the study, as we all know, screening mammography, when applied to the general population, will detect early breast cancer, which has a significant impact on reducing the mortality and the life expectancy of the women. It also detects, when we do screening, it detects small tumors which have a favorable biological feature which may not progress. However, all of them are traditionally managed with open surgery, which is basically a breast conservation surgery with sentinel lymph node biopsy. And vacuum-assisted excision has been used for almost 2 decades now for treating benign lesions and lesions with uncertain malignant potential. This study, SMALL, uses vacuum-assisted excision of small screen-detected breast cancers which have a biologically favorable features, and all of these cancers are detected in the UK NHS screening program. So the aim of the study is basically, as I said, this is a phase 3 randomized control study which aims in comparing the standard surgery with vacuum-assisted excision and seeks to determine, is this approach feasible and acceptable to the patients? And can it be done with an acceptable re-excision rate? And what would be the long-term local recurrence and its implications? And can sentinel lymph node biopsy be omitted in these group of patients? So the structure of the study is, as I said, it is a screen-detected malignancy, and the size criteria is less than 1.5 centimeter. And all of them, when they are screen-detected through a mammogram, undergoes a routine diagnostic core biopsy. And the key eligibility criteria is all women who are above or equal to 47 years on screen-detected mammography, and the size of the tumor should be less than 1.5 centimeter in its maximum dimension. There should not be any associated microcalcification outside the mass. Basically, it means that it should be just that 1.5 centimeters and shouldn't be any associated DCIS outside the mass. And it should be a unifocal disease, a grade 1 tumor, and they should be ER/PR strongly positive and HER2 negative. And they should have either a normal axillary ultrasound, or if there were some lymph nodes which were raised a suspicion on imaging, they should have a benign FNAC or a biopsy report. And they should not have any prior diagnosis of ipsilateral DCIS or invasive cancer. When the patient have fit into all these eligibility criteria, an informed consent was obtained and randomization happens. So on the randomization, one arm is the surgery arm, wherein they undergo wide local excision with sentinel lymph node biopsy, followed by a radiotherapy based on the local practice. If the local practice omits radiation, and they omit radiation, and they also undergo hormonal therapy. In the vacuum-assisted excision arm, and they are all with post-procedure. Following a vacuum-assisted excision, the excision completion is assessed by a post-procedure mammogram. And if they find that the excision is incomplete, they undergo surgery right away, which is the standard wide local excision with sentinel lymph node biopsy. And if the mammogram confirms complete excision, they undergo radiotherapy and endocrine therapy based on the local practice. What is the rationale behind the study design is, first and foremost, it is a randomized trial, and the end point is the non-inferiority of the vacuum-assisted excision, which means that the re-excision rate are on par with surgery, which is 15 to 20% in UK. And the data, the recurrences of following surgery and radiotherapy are less than 1% at the end of 5 years when they follow the standard surgery with the sentinel lymph node biopsy. So the acceptable recurrence rate should be less than 3% following an vacuum assisted excision, and anything which is more than 3% is considered unacceptable. So the primary endpoints are two. One is the re-excision rates, because even for a sentinel, even for a wide local excision followed by sentinel lymph node, the re-excision rates in UK, the data says is around 10 to 20%, and hence the same re-excision rate is fixed for vacuum assisted excision also. And the local recurrence based on the data of the standard procedure is less than 1% at the end of 5 years, and hence the vacuum assisted excision should have a local recurrence rate of 3% at the end of 5 years. They also have certain secondary outcome which measures the complication rate in both arms, the overall survival, the quality of life, and the cost effectiveness analysis. So the total of 800 patients were expected to be included in the study with 2:1. It means more women were selected for vacuum assisted excision. So the surgery arm will have 257 patients and the vacuum assisted excision arm will have 533 patients. And the total number required to assess the re-excision rate for the VAE has a little more than 5%, considering the dropouts. They have calculated an estimate of 762 women. And as I said, the probability of success in both arms is 80%, considering the 20% re-excision rates. And the minimum acceptable difference between both the arms is only 10%. And the total number required for calculating the recurrence is 511, with an expected survival after 5 years is 99%, which means there is only less than 1% recurrence rate at the end of 5 years. And the undesirable in the vacuum assisted excision arm is we have a survival rate of 97%, which is basically anything more than 3% recurrence rate is considered an undesirable survival. So the level 1 is basically understanding the recruitment process, and the level 2 is development and implementation of the recruitment intervention strategies. And based on this poster, they have published the data on recruitment and progress till 18th November 2021, and 18 centers from NHS are open for recruitment, and 10 centers have recruited 60 patients, and 55% of these recruited eligible entry have consented to randomization. So they also have mentioned, because the COVID has impacted this study, and hence not many numbers have been started as expected. And when I go through the literature, I see similar trials with VAB in the breast cancer. One is from Netherlands, which is a mini VAB, which also has got a very similar structural design, which is 1.5 centimeter non-lobular cancers. And they basically have, they should be hormone positive tumors. And this one is very interesting that it is not a randomized, and all the patients in this mini VAB undergoes both vacuum assisted excisions and 3 weeks later surgery, which is basically a lumpectomy with sentinel node lymph node biopsy. And the surgery is the vacuum assisted excision is considered successful when the surgery, the pathology from the surgical specimen says there is no residual tumor. And this is basically a pilot study. And as we all know, the cryoablation has also been used in breast cancer, and the phase 3 interim results of the ICE3 trial is published last year. And this is a prospective multicentric trial, again with women, but they are only when they are more than 60 years of age, and they have included low to intermediate grade tumor. And again, it is a small tumor, 1.5 centimeter, again a hormone positive HER2 negative tumor. And the 3-year interim results published last year said the ipsilateral recurrence rate was 2.06% after the cryoablation, and more than 95% have exhibited satisfaction on the cosmetic results. Thank you.